for folks during those presentations. And then we're going to have 2 discussions, and hopefully those discussions lead into plans or action items for future webinars to get more in depth on specific topics. And we're already having conversations about some of that subject matter, but we're really hoping to get direction from the audience to what's engaging to them, and how folks are viewing this. And so we'll get in more of that later on, but for right now, we'll start with Sam. He is the chairperson of the SILC and has given this overview of the Olmstead presentation to interested parties, housing advocacy, and other groups throughout the state over the past year or so. And we're happy to have it culminate in this. So Sam, I'll let you take it away.
Okay, thank you, Tom. And first of all, I do want to thank, obviously we can't thank everyone who's attending by name, but I do want to say that unfortunately Secretary Smith sends his regrets. He was called to testify at the last minute, so he cannot be here. But Commissioner Hutt is here. I do know that the Dean from Representative Welch's office, Congressman Welch's office, is here. We expected Sheila Reed and Polly Major from Senators Sanders and Leahy's office. I don't know whether they're here yet. I also want to make note of former Commissioner Patrick Flood, who is here, and former Commissioner Brendan Hogan. I do want to make special mention of them. So I will begin with basically an overview of what the Supreme Court of the United States Olmstead decision was and its implications, and then more specifically, how it relates to the state of Vermont. So I also want to thank actually Whitney Nichols, who's a member of the SILC, for providing us with much background information from the Bazelon Center and from other sources. So what is Olmstead? It was a decision handed down by the Supreme Court of the United States in 1999. Technically, it was LC and EW versus Olmstead. And Olmstead refers to Tommy Olmstead, who was the Commissioner of Human Resources for the state of Georgia. Case was filed in 1995 and handed down in 1999. The suit was brought against the state of Georgia for unnecessary institutionalization of people with mental illness or psychiatric illness specifically. The suit basically stated that there were no community-based supports available despite an agreement for community and independent living venues to be in place, and specifically that the assessments of these 2 residents were the community living was in their best interest. So that is the gist of the lawsuit brought against the state of Georgia. The Supreme Court ruling was based specifically on the Americans with Disabilities Act of 1990. The ruling cited the ADA integration mandate that such institutionalization and segregation was unlawful and unjustified isolation, and segregation and discrimination against people with disabilities. The ruling also stated that states and territories must provide services in the most integrated setting feasible. The decision basically applied the ADA protections to mental illness as a disability, and again, specifically to the public entities title of the ADA, which is Title II. It's important to note that technically when I say SCOTUS, I think you all know means Supreme Court of the United States, though technically the SCOTUS decision was limited to psychiatric illnesses, there's no doubt that a broader application was applied. In other words, to all and every significant disability. So the broader implication could be stated that no person with a disability should assume to be, quote, incapable or unworthy of participating in community life. And further, that confinement in an institution diminishes the quality of life and diminishes the opportunities for, anyone who knows me knows that I emphasize this, for employment, economic related, educational, cultural, and social advancement. So that is basically the gist of the Olmstead decision. I do want to make note of a caveat here, an important caveat, and that is the decision did not rule out institutionalization if and when appropriate. So it was not a blind decision, which would actually have resulted in situations that would not have been in the best interest of all people with disabilities. Further, the decision made clear that services and programs needed to be in place for people to be released from institutions. In other words, they can't, to use the vernacular, people could not just be dumped into the community. So, what are the implementation issues? First of all, as basically I said before, the SCOTUS ruling did apply to all 50 states and territories. The states were essentially mandated, and that's a strong word, but that's what the ruling did state. The states were mandated to transition people with disabilities out of institutions and into home and community-based settings if appropriate and feasible. And again, programs and services must be in place to assure safe placement. And I also want to make note that the implication here was that the entities did not unnecessary time to institute and implement these programs and services. So since the Olmstead decision, there has been movement forward. There's no doubt about that. But by and large, movement has been slow and halting. Particularly in terms of widespread and systemic reform. Why? Certainly, there are fiscal, as there always are, there were fiscal reasons and rationale for that, but also societal concerns and societal obstacles, as you might expect. Most of all, there were housing and transportation implications and impediments, as well as impediments regarding essential and accessible community-based healthcare services. And anyone who is involved in advocacy, for example, in the state of Vermont, would understand why. Medicaid home and community-based programs and services have been expanding, no doubt. But generally speaking, in terms of state implementation, they are optional and they are not fully implemented. So these are all really essential aspects to understand as to why the Olmstead decision and in turn the ADA integration mandate has not been fully implemented. In 2001, President George W. Bush began the so-called New Freedom Initiative, which basically pledged federal assistance to indeed implement Olmstead. And if you remember, his father, George H.W. Bush, signed the ADA in 1990. 43 states, including Vermont, created Olmstead commissions or task force. State Olmstead plans resulting from the work of those commissions or task forces were created with timelines and specifics to carry out the integration mandate. And what was strongly implied was that there be an appropriate shift in funding from institutional services, from institutional beds, to home and community-based programs and services. One example would be the Money Follows the Person, and I may use the acronym from now on, MFP, Medicaid Demonstration Project, which is embodied in the Congressional Empower Care Act, and which basically makes some, I don't think it's enough, but some money available for transitioning out of institutional living to home and community-based living. Recently, as it was actually in the third stimulus package, the COVID-19 stimulus package, Congress extended the appropriations for the Money Follows the Person through the end of November, through I believe it's November 30th. They extended it through May to November. It's going to have to be reauthorized. We're hoping for a permanent authorization, but it hasn't happened yet. What is pending? And this is quite important. Really, for the full intent and impact of the ADA integration mandate and the Olmstead decision to evolve, to be seen, the Disability Integration Act was introduced before Congress, and this has been sitting there for quite some time. Unfortunately, even though there are enough votes in the House as we speak on a strong bipartisan basis, it is sitting in committee and is not going to be brought for a vote before the House this session. The Disability Integration Act is broader legislation that directs states, again, to fulfill the true intent of the ADA integration mandate and the Olmstead decision. So what about Vermont? Vermont efforts. The Vermont Olmstead Commission was indeed created by state legislation in 2002. It was tasked, as we might think, with developing the state Olmstead Plan. The state Olmstead Plan, although more comprehensive and broader, and that's because Vermont has always been a leader in these things, is more comprehensive, broader than plans of most other states. However, the plan is not really a plan per se. The plan addresses so-called challenges, in quote, challenges. That's how it's stated in the plan. I believe there are 11 challenges to implementation. But are there specific routes to implementation in the plan? Are there specific timelines? No. So it's not really a plan, but the areas that require work and challenge, they are stated in the plan. Sadly, I doubt that the majority of current state legislators have even heard of the Olmstead plan. Figuratively speaking, the plan is in somebody's drawer someplace and really is not per se being considered. The plan was submitted to Governor Jim Douglas by the legislature on February 6th, 2006. So formally, it is a plan. There has been initial progress. I don't think there's any doubt about that. Actually, excuse me, Patrick is certainly with us and knows about that. But frankly, since early on, many initiatives have been stalled. Fiscal issues are certainly part of that, that led to delays in implementation. So why is the silk involved? And I think this is an important part of my presentation as chair of the silk. The statewide Independent Living Council indeed does have charge or purview of independent living, but encompassed in independent living is outreach and education about the Olmstead plan. And it also has the ability to advocate for implementation and follow progress of the implementation through the state plan for independent living, the 3-year state plan, which is the main responsibility per the Rehab Act of 1973 of SILKS, Title 7. SILKS do not have enforcement authority. I want to make that very clear. We are not a legal entity per se, but we certainly can and will and do monitor implementation. We are also increasing our efforts to partner, and this is one of the reasons for the series of webinars just after the 20th anniversary of the Olmstead decision. We are increasing our attempts to reach out and partner with other organizations, other entities, to continue the progress in implementing Olmstead. Want to make one other thing clear. Progress has been made, I will say, in the spirit of Olmstead, although not necessarily in its name. People might not have even known, as I said, about the decision. So one of the reasons for the SILKS initiative now is to make note of that progress, decide how far we've come and how far we need to go. And that's basically why we're here. And the subsequent discussions toward the end of this meeting will have those themes in mind. There's just one other thing I wanted to mention, and that is it's incredibly important to keep in mind the social determinants of health when considering independent living. In other words, if a affordable, accessible, integrated housing is not available, if transportation, if accessible transportation is not available, in some cases, if educational opportunities are not available, certainly if essential healthcare is not available, then independent living, for many people, falls apart. And we need to consider the holistic aspect of independent living, in addition to its cost effectiveness, but probably even more important than that would be the importance of allowing people with all types of disabilities to live with dignity, and to, if possible, be self-sufficient, and fulfill their potential as best they can. And that's what independent living is all about, and that's what the Silk is all about. So I think, Tom, that concludes my presentation. I hope I gave a sufficient and clear overview of Olmstead, of the ADA integration mandate, where we are now, particularly in Vermont, and where we need to go. And now I'm going to really throw it to Ed Paquin, who's the executive director, as we all know, of Disability Rights Vermont, to really put a real-time spotlight on what is happening now under the Olmstead banner, and what can be done, and again, keeping in mind what needs to be done. So, Ed. Okay. Okay, I don't.
There we go. It works much better when you unmute yourself.
Oh, okay.
Thank you very much, Sam. And sorry about that, folks. I am Ed Paquin, a little slow on the technology this morning, apparently. The director at Disability Rights Vermont, and we are the designated protection and advocacy agency for the state of Vermont. We are part of the national network of agencies that are federally funded to investigate abuse, neglect, and civil rights violations, and also to advocate for policies that protect and expand the rights of people with disabilities. Our state law also designates us to be the mental health care ombudsman for the state of Vermont. DRVT and the protection and advocacy system in Vermont has had a long history with deinstitutionalizing Vermont's system of disability services. The Disability Law Project of Vermont, of legal aid, which has worked as a key part of Vermont's P&A system since its inception. In fact, they were basically the P&A for a number of years. They played a key role in the closure of the Brandon Training School and DRVT's monitoring of institutions to facilitate individuals' return to the community preceded the Olmstead ruling. Throughout that monitoring and throughout years of outreach in psychiatric inpatient units, we have found numerous situations in which people faced lengthy delays in discharge, unnecessary institutionalization, and harm, and primarily for the lack of sufficient community capacity to be able to serve folks who'd gone through inpatient care. And this has been particularly true for those with a documented history of difficult behaviors that are related to mental illness or mental disabilities, and for those with complex co-occurring medical conditions, and for those needing specialized traumatic brain injury placements or other sorts of individualized services. Early in this century, Disability Rights Vermont participated in the creation of the state Olmstead plan, which Sam told us about. And we felt that it fell short of being a true action plan, partly because there was a belief at the time that Vermont already met the spirit of the Olmstead ruling. There was quite a hesitance to take strong action based on the progress we had made, looking less than at the promise of progress we could make. So I would now like to introduce A.J. Rubin, the Disability Rights Vermont supervising attorney, and Mary Postemski, our senior investigator. And they will lead you through work that shows that that assumption that we've already made the progress we need to make falls short, and that we have a lot of work yet to do in Vermont to meet the spirit of the ADA's integration mandate. AJ?
Thank you. So again, thank you to the Silk for inviting us to be here to talk today. We have provided a report about our findings about Vermont's Olmstead status, and I'm going to tell you sort of what led up to us deciding to create that report. You know, what led us up to creating the report was that we were encountering people who were being held up in institutions and hospitals for not just months, but sometimes a year or more at a time. And the processes and the systems that were in place had failed to help these people get them out in a timely manner. As you'll see detailed in the report, there were a number of people who had been held in psychiatric facilities for over a year because there was no place in the community that would take them, either because of their behaviors or for other reasons. The report was issued you know, a while ago, but even today, we are working currently with people who are held in psychiatric hospitals, even though they're not getting better, and in fact may get worse because of the unnecessary institutionalization. And so we were alarmed at these problems. People told us it was harmful to them. They often were subjected to additional uses of force and additional involuntary medication because they were getting so frustrated at being held for days and days and weeks and months with no real hope of getting out, just being told everyone was working on it, but they were powerless to get out themselves. So we consulted with a national expert, and we before that we tried to bring these issues to the Vermont Human Rights Commission, and I see that there's some folks from the commission here today, and I'm glad to have them be part of this presentation. We brought two cases regarding this concern to the Human Rights Commission. One of our clients actually passed away before the commission could make a decision after she had been held unnecessarily in a hospital for over a year. Another person was released soon after we got involved, but we pursued the claim. Unfortunately, the Human Rights Commission decided not to find that the state of Vermont was a responsible party in the over a year delay in discharge. And so at that point, we decided that we had to do more to develop a framework and a basis to fix the problem, because we weren't able to get it moving forward with the Human Rights Commission. So we contacted a national expert who had been a high-ranking official in several state departments of mental health and had been consulting with the U.S. Department of Justice on similar cases. And we brainstormed how to go about figuring out how to document the problem and how to demonstrate that there was a way to fix the problem. I think that, Mary, correct me if I'm wrong, but at this point, I'm going to ask Mary to sort of talk about what we did in the nuts and bolts of the initiative. Mary Postemski is one of our senior investigators who one of her jobs is to work in inpatient psychiatric facilities and work with people who sometimes are stuck there for a year or more. And so she's very motivated to help these people get out. And she's got a lot to say about what we did to sort of develop our report. So Mary, if you would take it away.
Okay, thank you, AJ. Thank you, presenters, and thank you everyone for being here. So as AJ mentioned, a large part of my role is working inside monitoring and conducting outreach in inpatient psychiatric facilities. And so the people that we have, we're talking about, the people that are summarized in our report, these are very real people. These are people that I know, that I've known sometimes for years, being stuck in hospital settings. So as AJ said, I'm very, very passionate about this work, and I hope that comes through here today. So what I'm going to do is talk about basically our report, what we did and what we found to start with. And I did, I believe Tom had shared a link previously, and I also shared a link to our Olmstead report in the chat room. So what we did to start with, we began our initiative by researching the data that was already available throughout, with a particular focus on Vermont. We reached out to other stakeholders through the system of care, peer advocates, Department of Mental Health, Department of Aging and Independent Living, the Long-Term Care Ombudsman, the Office of Public Guardian, and all sorts of others to really gain a better sense of the scope of the Olmstead problems, the unnecessary institutionalization that people throughout Vermont were facing in our hospital settings. We quickly learned, not only through our own anecdotal evidence, being in the hospitals and meeting with these people, but we quickly learned that the scope was very, very large. We decided, as AJ mentioned, to concentrate our initial efforts on individuals primarily with psychiatric and other co-occurring disabilities who are facing barriers to their timely discharge from hospital settings. In August of 2019, DRVT, that's Disability Rights Vermont, issued a press release to media outlets statewide, to designated hospital administrators, to inpatient psychiatric providers. We really wanted to publicize this initiative, our Olmstead initiative, and seeking their assistance, the public's assistance, providers' assistance, to identify and offer our assistance to individuals whose Olmstead rights were potentially being violated. Our facility advocates, including myself, then met with inpatient psychiatrists, with social workers, and with discharge planners at each of the designated hospitals to discuss the initiative and really extend our offer to work collaboratively with them to address barriers to discharge for their patients. We, of course, through our regular visits, outreach, and monitoring to the hospitals, we continue to receive requests for assistance regarding delays in discharge directly from the patients themselves as well. We then developed a uniform set of data that we wanted to gather for each individual referral in order to document key aspects of their situation for individual case advocacy and also to use in our systemic analysis. This data included date of admission, the reason for admission, what types of community-based services, if any, were in place at the time of admission or just prior to their admission, the date, and this is an important one, the date they were deemed subacute, meaning the date they were found to no longer be in need of inpatient level of care. That's a designation by the hospital providers, a psychiatrist, nurse practitioners, and such. And so there's so many people, why that I want to emphasize subacute. That's the date at which truly the person no longer needs to be in the hospital, but was stuck there. We documented client discharge preferences. What does the client want? At Disability Rights Vermont, we are client driven. We advocate for what it is that our clients, that people we serve, are telling us that they want. We documented discharge recommendations by providers, and then looking at what was already identified in terms of barriers to their timely discharge. So for each of these individuals that we began serving, and providing Olmstead assistance to, we became actively involved in the discharge planning. Essentially, we inserted ourselves directly into the process. We became part of the team. We attended and at many times initiated regularly scheduled meetings, putting into place a schedule that we could discuss what the barriers were, that we could, we really wanted to be part of the team, looking at how can we best address those barriers. The teams included the inpatient providers, outpatient providers, care managers from the Department of Mental Health, Department of Aging and Independent Living staff, and patients and their guardians when applicable as well. So as I mentioned, our primary role consisted of working with the discharge planning team to brainstorm options, to develop effective work plans in an attempt to obtain prompt and appropriate placements. We identified specific follow-up tasks and determined individual responsibilities of team members to complete those tasks. We requested that the state provide enhanced residential rates or other appropriate supports for augmented services in community-based placements when appropriate. We requested continual follow-up meetings to monitor the progress made, to keep people on task, to keep these individuals who are facing unnecessary institutionalization in the forefront of all of our minds. And then we, in some cases, reached out to commissioner level and deputy commissioners of mental health and Department of Aging and Independent Living Services, who I think is on this call. We really, in some of the most egregious situations, we wanted to seek out the highest level of help to assist our clients to no longer, to break down those barriers to appropriate discharge. And I'd like to say, importantly, throughout each of these meetings, DRVT, Disability Rights Vermont, we remained a constant voice, reminding everyone involved of the patient's right to receive services in the least restrictive environment. We advocated for and we preserved patient preferences with regard to proposed discharge placements. We worked together with the providers and the state care managers and the leaders in the system to no longer allow the status quo of people being essentially warehoused in hospital settings for weeks, months, and sometimes years at a time. And I have to say, in my personal experience, being involved with, in these discharge team meetings, I really found there are certain providers, their care managers, certain state, members of our team their voice became more and more common and constant in terms of protecting the Olmstead rights of these individuals. And for that, I truly am appreciative. They're bringing this work forward with us all together. So the next piece of what I'd like to talk about is what we found during this really focused initiative on the Olmstead situations. So quickly, I'll run through a list of commonalities that we found throughout this work. And in fact, Ed had mentioned some of this earlier. But most often for patients facing barriers to discharge, there were certain clusters or cohorts, if you will, of people affected. And as Ed mentioned, most of these individuals had one or more of the following characteristics. People with complex medical needs, in addition to any sort of mental health history. People with psychiatric disabilities who also had documented incidents of, as Ed put it, difficult behaviors. Primarily the people who are facing the longest barriers to discharge, falling into that cohort, were those who had any type of assaultive behavior, even when those behaviors were not occurring presently during their hospitalization or even in the remote past. If there is some documented history of that, these folks we found to be more likely to face delays in discharge. We found the group of folks who experience both mental health and intellectual disabilities. That was also folks who are facing lengthy barriers to discharge, people on the autism spectrum, people with traumatic brain injury and mental health disabilities. The folks who really needed more intense community-based specialized services that there just isn't enough of to go around in our state. And then finally, geriatric patients. Those are particularly older adults with dementia or Alzheimer's or other similar disabilities that again need more specialized treatment and care. We also found, I'm going to just take a break here. We also found several common barriers to timely discharge. First and foremost, the lack of sufficient community capacity to care for individuals with specialized needs. For people needing skilled nursing homes, assisted living facilities, adult family care homes, intensive residential placements, or other specialized service placements, there are very long wait lists. The most common response received from these places upon receiving referrals was, "We have no beds." A contributing factor to this that we found had to do with an insufficient workforce throughout Vermont. Some placements actually did have beds, but they did not have enough staff to operate at full capacity. The next most common response we received in terms of referrals to appropriate community-based placements is those placements saying, quote unquote, "We cannot meet their needs." So unlike our state's licensing regulations for in-home health services, such as visiting nurses, those types of things, which I understand are required to serve eligible individuals within their catchment area, Vermont's nursing homes, our assisted living, our residential care home, those licensing regulations allow those types of placements to decline to accept individuals based on their own assessment, which often boils down to that one phrase: "We cannot meet their needs." While I would suggest a more rigorous analysis needs to be done on that issue, we did often sense a subtle, and in some cases overt, discrimination, if you will, resulting in people with histories of mental illness, histories of difficult behaviors, really not being accepted into facilities who were not specifically designed to care for the segment of our population. And those facilities that are designed specifically, like our intensive residential care homes, recovery homes, our other residential group homes and such, again, they're so limited throughout our state, there's just not enough. We also found an overall fragmentation within Vermont's mental health system of care. In some instances, there were interagency and funding silos that needed to be broken down. In other instances, there were conflicts between recommendations, between discharge recommendations to a lower level of care, such as independent living, that may have been made by inpatient providers versus a higher level of care recommendation by outpatient providers. We heard from outpatient teams or I personally heard from outpatient teams wanting much more restrictive discharge placements, such as nursing home or residential care placements for their clients, because in their words, the person had a history of failed attempts to live on their own. I will add that in some of these instances, when our client's preference was to return to independent living, I found there were definitely some great advocates within the system. Inpatient providers, there are care management champions teaming up with us to successfully combat some of the more restrictive or coercive nature of outpatient provider recommendations. Another very common barrier was homelessness. People who had come into the hospital already homeless, coming from motels, coming from shelters coming from the streets, the tents, etc. And others who had lost their living arrangements as a result of sometimes the behaviors that led to their inpatient hospitalization, and other times just the mere fact of the months or years that they were hospitalized. These people literally have nowhere to go, but they were not deemed safe to discharge directly to the streets. This took a lot of team effort and coordination without a lot of available housing resources in our communities, delaying discharges even more. Systemically, and I am going to have AJ talk more about this, but just very briefly, we found there was a lack of follow-through, not completely, not entirely, but a lack of follow-through on some aspects of the state's, Vermont's own independent consultants report that was issued in 2012. And I'm going to share a link to that because I found it very worthwhile to read. So there's a link to that in the chat. There's pages and pages of recommendations to improve Vermont's mental health system of care. And many of those focused on wanting to prevent unnecessary hospitalization and to really serve people in the communities. We found that there was a lack of a systemic and coordinated sort of oversight and practice, consistent practices throughout the state across the mental health and the aging and the disability system of care with regard to facing barriers to discharge. Oftentimes, we have care managers in different parts of the states. We have advocates, investigators such as myself in different parts of the states, working with different people facing unnecessary institutionalization, and we're all competing for those same limited resources in our state. So some type of, just keep that in mind in terms of how can we really come together and the overall system work together for these folks in an improved way. And then finally, we found a lack of focus by the state on preventing inpatient admission. And again, I'm not trying to generalize, it's not always the case, but certainly, my experience working with folks is, there's, in looking at the system of care, there's been, especially recently, more of a push to invest in even more inpatient capacity, whereas looking at, what would be most helpful to build a robust and adequately funded community mental health system, one that employs evidence-based practices consistently throughout the state, more alternative modalities, more peer services, and other safety nets that would, how can we successfully divert people from hospitalization in the first place so they don't end up being stuck there. So with that in mind, I will turn it now back to AJ to talk more about our policy recommendations. Thank you.
Hi, so we did eventually issue a report based on the data that Mary and some of our other colleagues at DRVT collected and that we shared with our expert consultant, Melody Pete. And that report came out in March. Here's a picture of it. You can get it on our link. It's called Wrongly Confined. And it did make several policy recommendations, 6 policy recommendations that are basically what Mary has talked about. So I'm not going to repeat them. But I think the important takeaways from Mary's and our experience is that everybody in the system really identifies the need to prevent these unnecessary delays, but the system just is not built right now to effectively do that. What's true is that for the 27 individuals that DRVT worked with that we documented in the report, our work was important in speeding up their eventual discharge. And that's unfortunate because we can't get in contact with every single person who's being delayed. And so our policy recommendations are an effort to move the progress from an individual by individual basis to a more systemic basis. And they include things, as Mary said, acknowledging the fact that there is a problem with Olmstead and putting the requisite resources in terms of staff and supports and housing in place. I think what's great about Silk inviting us here today is that this helps us get out the word that there are people every day, people with real lives who are being affected and harmed by the fact that they're not being able to leave the hospital. And that on top of that, it's a waste of money. We could do better, cheaper, and more humanely. So our policy recommendations in the document are well worth reading. We issued it in March in the middle of the pandemic. It didn't get a whole lot of feedback, but we are continuing to use it as we make recommendations in the individual cases we're working on. And it is our hope that the policymakers that are on this call today and the legislators who may have read this will work with us to make the progress that Mary's talking about, that we also recognize. But I think what I'm here to say is the initial starting point to recovery from our Olmstead problem is a strong acknowledgement that there is a problem, that if there are 5 or 10 or 15 people at any one moment who are being held up in hospitals around the state when they don't need to be there, that's a problem for those folks. It's not such big numbers that we can't fix it, but it does require a restructuring of the way we're doing it. And it's going to take leadership from the state of Vermont to say that there is a problem and we're going to put the resources towards it. Our recommendations are not really rocket science, and they've been made, as Mary said, years before. So we're trying to reiterate that while we're continue to do the work on an individual basis. So I think I'll let Ed sort of sum us up in terms of, oh, actually it's back to Mary on what we're doing currently, because we are continuing to build our capacity to make an impact on this. This presentation is one effort to do that. Making sure people are acknowledging the report is another, and doing the individual casework is a third. But Mary's going to talk about some other more collaborative initiatives that we're going to be starting and are working on currently, again, to sort of raise the profile as a way to get all of you and all of the people who you come in contact with to help us solve the problem and prevent these unnecessary delays. So thanks for your time. And Mary, it's on your watch.
Thank you again. So very briefly, as AJ mentioned, we continue to work on these individual cases with these individual patients, clients, and really attempting to utilize the recommendations in our report to both facilitate appropriate and timely discharge from inpatient units and to continue documenting the failures of the system. Looking at the procedures that we can employ to assure that unnecessary avoidable institutionalization is prevented. Right now, I'm pleased to say that we've launched a collaborative effort with our partners at Vermont Legal Aid. And in fact, I want to say thanks to Jill Rudge, who I believe is on in our meeting today. With her, we're currently working on a survey to be sent to clients receiving, to persons, consumers receiving community mental health services throughout Vermont, really with a focus on assessing how mental health and supportive services during the pandemic have changed for them, looking at the impact of those changes, and importantly, looking at lessons learned directly from people receiving services that they think are helpful and that they want providers and decision makers to know. We're also working on a similar survey for providers of community mental health services. And I have to say, the designated agency system and Pathways and also Vermont Care Partners have been very helpful in promoting, and helping us to promote this project. Really, we want to look at this pandemic gives us, we know that There's been a decrease in presentations by people in crisis to emergency departments. When people are in emergency departments, they often end up in the hospital, and some very well, appropriate. For many others, when they're, they end up in the hospital and then they're stuck, as we're talking about here. We're also noticing a decrease in the rate of hospitalization. And so we really want to look at, we have this rare opportunity during the pandemic to look at what changed, what made that difference, what caused people to be able to remain and supported people to be able to remain in their communities safely rather than in a hospital setting. And we want to build upon that. So even though our Olmstead initiative, what we talked about today, what you'll read in our report, focuses primarily on people experiencing Olmstead right violations in inpatient psychiatric units, we really have not even scratched the surface of so many others throughout our state facing the same violations. People stuck in hospital medical units, in nursing homes, in residential care homes, and other more restrictive settings that these people may not need or want. So I encourage you, as we think about the discussion moving forward and next steps, how can we broaden, how can we come together and work towards solving some of these rights violations? So I'll end here with a quote that I heard on the news last night. It says, "The first requirement of leadership is you watch over people in your care." And I implore all of us to be leaders, and all of us, for the sake of the people that we serve, the people that are our friends, our family members, our peers, our citizens. I implore you to step forward and help. So thank you, and I'm going to turn it back to Ed, who will lead us into a question and answer, and the next part of our presentation, which is actually opening up for discussion. Thank you.
Thanks, Mary. And really, this is where you folks come in, all of you folks who are listening. At DRVT, we picked a focus, and we worked with some intensity in a particular area. We'll continue to do that. But we need your input. We need you to help us find the clients, to help us understand what advocacy needs to happen in Vermont, and to offer your wisdom, frankly, as to how to make community integration more of a reality for people with real needs that don't include inpatient treatment, and to help us ensure that people with disabilities have the opportunity to access all that our society has to offer. Thank you very much, and I'll turn it back over to Tom, I think, who's going to lead us into the discussion.
Yeah, thanks, Ed. And before we move on to the discussion component, and thank you, Mary, for that quote, one of the things that's coming up now that feels like it bears mentioning is the fact that one of the plaintiffs in the Olmstead decision was a person of color, Lois Curtis. And so given everything that's going on, particularly today, and still deciding to have this meeting, part of responsible leadership does feel necessary to point out that fact during a coordination of Black Lives Matter, that we raise up Lois Curtis as a person of color in a leadership position that allowed us to have this conversation today. So I just wanted to put that out there. If the conversation wants to continue to go that way, that's fine with me. But it felt important to say that. So thank you for that.
Tom, if I may just interrupt for a second. I just want to make clear that Sheila Reed from Senator Sanders' office and Pauline Major from Senator Leahy's office are indeed on the phone. There are Senate rules about not joining a Zoom video conference, so they are here. And also wanted to thank Hillary Melton, who is Executive Director of Pathways Vermont and is Chair of the Silk Housing Committee. Hillary has been instrumental in planning these Olmstead meetings. And also Tim Bradshaw, who's a top policy person at D-Trans, has also been instrumental in the transportation connection to independent living. He's chair of the Silk Transportation Committee. So one other thing, I mentioned the state plan for independent living prior. The state plan for independent living is in the process of being submitted to the federal authorities by June 30th. And anyone, any member of the public, anyone here who wants to expand on anything that's being said in terms of Olmstead implementation concerning transition from corrections facilities, please feel free to email Tom, myself, or both to make comments in the goals and objectives of the state plan for independent living. Thank you, Tom. I'm sorry, but I did want to mention that. It's very important.
Sure. Yeah, so we will take questions based off of the presentations that were put forward just now, and then we'll move on to the discussion topics in the program. But I will just leave it open. I'm not seeing any questions currently. I'll just leave it for a little bit to see if there is anything to answer, and then we'll move on to the next discussion topic. And I would mention as well that if people have questions that are germinating for them, please feel free to reach out to me and I can connect you with the appropriate presenter or information source. This is a conversation that can be, ongoing. And as mentioned before, we will continue to have these webinars. Oh, I'm getting a hand raise, so let's go to Sarah.
Hi, everybody. I saw Patrick's hand go up right before mine, so I can yield it to you if you want to do it first.
Oh, there you go.
Okay. Thank you, Tom, for bringing up the piece that you brought up. It's really, really difficult for me to sit on a call today and not talk about Black Lives Matter and what's happening in our world. And so I think, and I wonder about the report that has been presented and the intersectionality of that and how we're going to be able and how people are reaching out to the Black community around this. We know that COVID-19 is affecting that community more than any other community at this point. And it's all our people. It's all people with disabilities. So I think as we move forward, we need to be actually saying out loud how we as a community, a very white call as we look across the video for people who can't see it, how are we going to address this and make sure that we're saying out loud how we're going to do it. And I know that DRVT, you do a great job around intersectionality and work around that, and I appreciate so much of what you've done in this report. Having been serving lots of time in mental institutions, you all know how much I appreciate the work that you're doing, and I just want to rise up that issue as well. So thanks so much.
Thank you.
I'll just say thank you, Sarah. The National Disability Rights Network made a statement that really said better than I can say about the intersection. This is about people, period. Human beings. Black Lives Matter. The lives of our people with disabilities matter. They're not to be separated, these kinds of issues. And I think that's one of the things that in past years where one movement goes this way, another movement goes that way. As Dr. King pointed out, when there is injustice, none of us are free. So I'll leave it at that.
And Patrick Flood wanted to say something.
I do. Thank you, Tom. Can you hear me?
Yep.
I want to say a couple of things. First of all, I would just second what Sarah and Ed were saying, that really the sources that are causing these problems are the same sources. That's a big philosophical discussion we don't have time for today. I wanted to just make a couple of quick comments on the presentation about mental health. First of all, I thank Disability Rights for their work. I read the report. I think it's an excellent report. What's discouraging is that there are the same issues that we were dealing with in 2012, which they highlighted. And really, the past almost 8 years now have really been disappointing in terms of the progress that could have and should have been made. And I just want to say make a couple points that I don't think they made in the report that I think are really helpful or really important. Number one, you'll always hear there's not enough money. And I have learned since I left state government that that's a certain amount of bullshit. There is plenty of money in the system. Our healthcare system in Vermont spends $6 billion to serve 600,000 people. Most people don't realize that. They don't realize where the money goes. We are wasting money left and right. And if that money was redirected, we could solve all of these problems. I absolutely assure you of that. But the hard questions are going to have to be asked about where the money does go. I'll give you one quick example. We have an accountable care organization in this state that's supposed to be leading healthcare reform. First of all, they're accomplishing nothing for 3 years. And second of all, they cost us $20 million a year. Now, how do we find $20 million a year for administration of an ACO, but we can't find money for housing, we can't find money for care to get people out of institutions? There's something very wrong with that, which leads me to point number 2. In all the sources of the problems that were identified in the Disability Rights Vermont report, which I agree with, one has not been sufficiently identified, and that is that the hospital, in my opinion, just my opinion, actually control the mental health system. The state doesn't. The Commissioner of Mental Health certainly does not. The hospitals do. Like the nursing homes, they get to say who they admit and who they don't admit. And until that issue is addressed, we're going to continue to have a medically based, institutional-based mental health system. So it's got to be addressed. It's got to be talked about. And the third thing, which the report does identify, but really does need to be discussed in much more detail, is leadership. There's been a lack of leadership for years in the Department of Mental Health and in the Agency of Human Services, as far as I can tell, about mental health issues. And it's not clear, as the report identifies, where the point of accountability is. And the point of accountability should be with the state, and I don't think it is. I don't think the state makes the key decisions. They're making almost no decisions. So I could go on and on. I'm not going to do that, but I wanted to make that point. And if those points, and if the Silk is interested in getting into more detail about this, I'm happy to spend the time doing it. I've spent a lot of time in the past couple of years looking at the problems in the health care system in Vermont. And I can tell you there's lots of opportunity there to do things better and to serve people better. But that's way more complicated than we have time for today. So thank you.
And Patrick, this is Sam. I do want to mention that there'll be many opportunities going forward. We will have further webinars in the series, and when circumstances allow, we will have an in-person meeting.
Yeah, thank you, Patrick. You know, I've heard you speak on the healthcare system pretty extensively and feel like you do a very good job and would love to make more space to make that a priority moving forward. So definitely would like to raise that up. Do we have anyone else who wants to say something currently? I don't see anyone.
I would like to.
Sure.
I thank you, Patrick, for saying what you said. I also want to ask, Ed, what kind of education do private and public guardians receive about Olmstead and their legal responsibilities to the people that they are guardians for?
I'll just try and answer that really quickly. and that is, I am unaware of what education private guardians get. The Office of Public Guardian that with the state, from my experience working with them, they work pretty hard to get people in community placements. And most of their people under guardianship are in fact in some form of community placement. I don't think the issue is their will. The issue is whether or not the appropriate placements are available and whether our community system gets the emphasis that it needs to get. And just to add one more phrase to that response, I don't disagree with anything that Patrick said on that subject. We've certainly advocated for more resources to go to community community placements, to community services, community supports. But that's not where the emphasis is. And he's correct to identify that that is not where the power is in the system.
Thank you.
Thank you, Sharon and Ed. We're gonna let Erhard, and then I'll read a question from Missy.
Thanks, Tom, and thanks, everyone. I had to jump off the call for a bit, so Ed, apologies. I did not get to hear your presentation, but look forward to reading the report. I guess representing the Vermont Affordable Housing Coalition, I just want to make the point that, you know, folks, and this builds on what Sarah was saying earlier and some of what Patrick said. You know, we know that people of color are disproportionately affected by COVID-19. We know that people of color are disproportionately represented among our homeless count. And a lot of this has to do, and certainly also clearly people with disabilities, clearly a lot of this has to do with housing and comes back to housing. And we are just not making the investments that are needed into housing, whether it's Housing First by Pathways, which is, I think most folks know, provides Housing First supportive services to folks coming from chronic homelessness with mental health disabilities and other disabilities. We're just not investing enough, and that's part of, you know, that's part and parcel of how we can implement and do better in terms of Olmstead and supporting people to live in housing in the community independently with the supports that they may need to live independently, integrated into the community. And this goes back to Patrick's point. You know, there is a lot of money in the system, and it is not necessarily being deployed in the most effective and efficient manner. I do think we're going to see, given the revenues that are being lost state revenues that are being lost as a result of COVID-19, and the projections are pretty dire. One of the things that I think as a community we all really need to watch out for is that we don't have this kind of this mindset of austerity, and that in order to get out of this dire revenue loss hole that the state is going to find itself in when lawmakers come back in August and September to do a full fiscal year 21 budget, that the way to get out of this is by applying austerity, because we know when austerity gets applied, it's folks with disabilities and people of color and other folks who are vulnerable that get shortchanged and don't get their needs met. There is enough money in the system. I guess one thing I would say that might be encouraging is that due to the state's revenue losses, they're going to have to really take a hard look at where they're spending the money. But we all are going to need to be there to make sure that they don't take away the supports that are needed for folks with disabilities to live independently integrated in the community, and that they don't take money away from the essential housing and supportive services and rental assistance that are needed as the foundation for people to be able to live independently in the community. And just, I guess we're going to talk later about you know, other webinars, but you know, I'll just say for folks who may not be familiar, and Hillary's on the call and may have spoken while I was off, but one of the things I would suggest is that you know, at least part of one of the next webinars feature the Housing First model in some depth, so that folks who are not familiar with it really get to understand, that it is really the best model for folks that are coming from homelessness with severe, especially mental health disabilities, to live independently in the community and have that solid foundation that they need to lead more fulfilled lives.
Thank you, Erhard. And yes, I agree. I think the Housing First model is its own webinar that should be addressed in a future session. And I'm sorry, I missed Susan Aronoff, and people were trying to get to put my attention to her. So I'll let Susan go, and then I'll get this question, and then we'll go to Mary.
Great, thanks. Hi, everyone. First of all, I want to thank Sam and Tom and the Silk for bringing us all together. We are in such a strange time, and I want to really thank Sarah for bringing up how white we all are. We are too white for this day and age to be having this conversation about these topics, that when we know there's such a difference in impact on our communities of color with all of these issues that we've talked about: institutionalization, segregation, isolation, everything. So thank you. And then I also want to clarify that, so for those of you who don't know me, I do the policy work for the Vermont Developmental Disabilities Council, and we didn't hear very much about people with developmental disabilities in this webinar, and so I just want to clarify for everyone, just so that everyone is aware that the Olmstead decision applied equally to people with developmental disabilities, and the institutionalization and segregation and separation of people with developmental disabilities. And that while we don't have an institution in Vermont today, we still do continue to have a lot of separation. And I think I would like to see a future webinar that talks about what the state is doing in terms of its implementing its home and community-based rules. We are the last state in the country right now to implement the person-centered planning aspects. That's the whole conflict of interest-free case management issue. And I think this is just such a critical time to look at how are we providing services to people in the community? How are we providing for choice and opportunity and integration? And until we implement conflict of interest free, I mean, you can't even start that process unless you have conflict of interest free case management. So I hope we can move that discussion forward and maybe have a webinar on the status of home and community-based rules and the law in Vermont. Thank you.
Thank you, Susan, and thank you for highlighting those points. I think that's a very, very important topic to cover, and we are actually, the Silk has commented on the implementation of conflict-free case management, and I've personally been in touch with mental health departments, Washington and Lamoille County in particular, about their starting to implement those, and I would love to connect with those folks as well and have a conversation about what that's actually looking like. And so that's great. That's exactly the kind of talking points we're looking for. I will read Missy's question now, and then we'll go to Mary. And excuse me, I just have to go up a little bit. Missy asks, do you have data for deaf people who know sign language? Also, I'm sure there are many hearing loss people who don't know sign and feel unable to communicate with doctors, nurses, etc., healthcare professionals. And I don't know who the appropriate person to jump in and answer that would be. Sam or Sarah, do you have, or Ed?
I can just say that statistically, I think it's somewhat under 3,000 people for whom, Vermonters, for whom American Sign Language is their first language. And I'd be happy to be corrected on that, but I think that's a stat that I heard a while back. During the COVID crisis, there has been, I'll turn it back to Missy because I think she's going to give me an answer.
Well, my point is that you know, there's not interpreter services or communication access, that's also a barrier. And even before COVID, pre-COVID, you know, post-COVID, doesn't matter. We can talking about live interpreters, we can talk about video access interpreters. There's all sorts of issues with all of that. But if you don't have that access in the first place, then it makes all of these, you know, first of all, the symptoms and the discovery of these symptoms much worse and much more difficult.
Yeah, I would agree with that. And I think that this whole practice of wearing masks, which I heartily support, but when healthcare delivery is going on, it's going to affect it's going to affect lip reading. And we have also seen, and some of the good work that the Disability Law Project has done with hospitals, the availability of live interpreters, the consistency of when they're using remote interpreters, it's not consistent. Parts of the hospital don't get reception and things like that. And then they also find that staff don't necessarily know how to use these accommodations. And so I think Missy's pointing out problems that have existed and are exacerbated, certainly by the kind of isolation and the kind of environment that's in our hospitals today.
Thank you. And I have Mary next. And please, you know, if I'm missing anyone, just use the chat feature to point me in the right direction. I appreciate people, and I apologize if I'm missing you. It's not intentional.
Okay, thank you. Excellent discussion. I wanted to loop back to something, and basically the discussion that I believe it was Erhard had mentioned, and about housing first models. When I was speaking earlier, I talked about our state not having employed consistently throughout the state evidence-based and best practices in terms of the delivery of community mental health services. I will say when we did our research, we found that, and when we consulted with national expert Melody Peet, what's recommended is most often to decrease institutionalization, to prevent hospitalization, is a very robust evidence-based assertive community treatment model, the ACT model it's often called. And what we found, I believe, is that Pathways Vermont is a great model, is an example, is a leader in our state for delivering that type of model. And so thinking about, again, the fragmentation within our system, you know, our designated agencies, not to take away the fact that they are also employing around the state different evidence-based practices, but consistently looking at, as a state, can we come together to operationalize, you know, statewide some of these best practice models. Also, I wanted to point out in our report recommendations that came directly from the expert that we consulted with in terms of the key services needing that reduce the need for hospitalization, and you've mentioned them already in part of this discussion. One, essential crisis services. I just mentioned assertive community treatment, and when I say assertive, that's not meant to, that's the name of it, that's not meant to be taken as coercive in any way, I hope. Intensive case management, peer support, supported employment. That's something that we haven't touched upon as well quite yet in this discussion. And then finally, as was mentioned, permanent supported housing. So I wanted to let you know those are recommendations in our report, and we do want to work together with you to operationalize those. Thank you.
Thanks, Mary. Susan Yuan, if you have anything.
Unmute. Can you hear me now? Okay. There are a couple of points that I wanted to make. One has to do with a program that is available. It's been around for a couple of years now. It's called the Comforts of Home program through Upper Valley Services. And for people who have been stuck in hospitals who have some behavioral issues, Comforts of Home has been able to get some people, particularly with combination of medical issues and behavioral issues, has been able to get them into community settings. So for people that want information about that, you can access through Upper Valley Services, the Comforts of Home program. And it's the most rapidly growing program right now that Upper Valley Services has because of the need. And the other thing that I want to bring up is my constant idea that many people with disabilities of a range of disabilities can successfully parent without their children going into the system. If they have the support of a program that was very successful in Vermont for a number of years, providing peer navigators who were very inexpensive and were very successful at providing the supports to help people keep their family member, keep their children successfully in their care, successfully and safely in our care. And that program was dropped because budgets got cut, were very tight at the time that the grant was over. But that remains the program with the best history of actually preventing children from going into custody out of their parents' care. Eric, can you kill that phone? Thank you.
Thank you, Susan. If anyone else has anything to say, we can take any more questions or comments, or we can move on to the next discussion topic. Not seeing anything, so let's move on. And again, if you have any other thoughts, please feel free to reach out. Oh, I see Sharon coming online, so let's give Sharon a spot.
Tom, I would just like to make the suggestion as we look at Olmstead and all of the population of folks with disabilities, that we look on a more functional basis so that services can be designed. And it doesn't matter whether you have mental health issues or physical issues or hearing issues or anything else. It's based on how a person can function that would get them out of nursing homes or hospital and into community-based settings. So I really think the state has siloed all of us into different categories of disability, and that may be what is keeping us from being looked at as how do we function and what services are needed for that person to function as independently as possible.
Great. Yes, thank you, Sharon. And I think, it's really important to look at how those assessments are being made. And I know they're changing. I don't feel like I know enough to comment on that right now, sort of off the cuff, but I know a lot of those assessments are being looked at and reevaluated and changing in different ways. And we should definitely be paying attention to that from the perspective of, is this siloing or is this helping be integrative? that's definitely a future conversation. If we have anyone else for questions or comments. I'm not seeing anyone, so let's move on. Our first topic of discussion would be, and we've definitely been touching on this as we talk and during the presentations, but what progress has been made in Vermont? What's Vermont doing right? And what are the gaps most specifically? And I know a lot of folks have a lot to say on this. I have a lot to say on this too. But I would just open it up if people have suggestions of, and it can be personal experience or systems level, you know, what has worked here, what are the pros, and what are the gaps in the Olmstead plan for Vermont. Yes, and as Mary's pointing out on the chat, if you hit, I'm sorry, I meant to say this up front. If you hit *9 and you're on the phone, you can essentially raise your hand for me to open your line. But right now we're gonna hear from Sarah. So you can go first, Sarah.
Hi, Sarah. Launderville, I actually was remembering the last part of your question and not the first part, so now I'm going to embarrass myself a bit. But the last part was something about the plan itself, and I don't think we have a plan. I think that we have a really good outline of what Vermont offered back when it was written, but I don't think that there's an actual plan of something moving forward as a group of us. And so, if I was to change something, I would actually create a plan that we could all use together. And I know that you were asking for what we do right, but that's what my comment is right now.
Yeah, thank you. And that's a great prompt. Yeah, I agree. And I do. And I think there are other people on this call who can speak to that better. And Sam and Mary and AJ and Ed have already all touched on some of that. But I agree. And part of what I see as coming out of this discussion is some action items potentially, so that there can be more concrete plan development in terms of goals. And as Sam mentioned before, where the Silk is doing its 3-year state plan currently, and that's a big priority for us. And it's not really intentionally not trying to detract from the things that have been put forward thus far. But what we're dealing with is that we have in our current plan, we have a lot of really mission-based stuff. We have a lot of really idealistic, lofty ideas, and we're being very careful in our internal conversations not to lose any of that, but put some really actionable steps in place for what we can do over what period of time, be it 1 year, 2 years, 3 years. And so, I would think that the same sort of applies here. We have a good basis, and I think we do a lot right. Patrick pointed out some stuff, Ed pointed out some stuff. There's always room for improvement, but it's not to say we don't have a plan, meaning we're not doing things correctly. I think we're doing a lot correctly, but can we really make some tangible items to advise on coming out of that? And I do see some hands raised. We have Sam, and then we'll go to someone on the phone.
Okay, for some reason it won't let me type in. I don't know why. In any event, yeah, I really just wanted to second what Sarah said, that perhaps we can use these series of meetings to indeed, even if it's not, formal state plan adopted by the legislature, but to indeed create some type of actionable plan. Because as I said during my presentation, the Olmstead plan is not really a plan. It's a list of 11 challenges, but no plan, no timeline. It doesn't say, you know, how to go about correcting any deficiencies. So perhaps the silk can be instrumental in using these series of meetings to indeed create some kind of a plan that's realistic, that's feasible, and that can be done.
Great, thank you, Sam. And now we have one hand on the phone, and so I'll unmute you. And please, if you're on the phone, please state your name, since no one can see a name attached to the phone number.
Hi, this is Deborah Lisi Baker, and I couldn't, Zoom wouldn't let me get on the video, so I joined by phone, and I've really appreciated everyone's comments. I just want to follow up on the excellent suggestion about getting a real Olmstead plan in place, and I think you could have both a formal Olmstead plan that's adopted by the state, or at least a proposal and legislative advocacy for it, but also something from the Silk and its partners to really push for that. I think there's been some really powerful information from the people who've spoken today that could be used to develop that. It's been, I mean, I can't remember, but my memory is that when the Olmstead plan was developed, it was intended that those challenges would be used to develop up-to-date plans for action, and that hasn't happened. But people can correct me if I'm wrong, but I don't see why there wouldn't be any reason to try to get more measurable goals and objectives into a state Olmstead plan that represents the current social environment and what really needs to happen, with the kind of concrete recommendations that people have been making today and could make at some of your future forums. I think that would be very powerful, and could include some of the stories of people affected by the lack of an Olmstead plan.
Thank you, Deborah, and glad you got on. Thank you for the feedback as well on that, and we can work toward making sure you can get on video if that's preferable in the future.
I usually don't have a problem doing it, so there's something happened today, I don't know why. But the only other thing that I wanted to mention is that I really appreciated, I appreciated everything in the Disability Rights Vermont report, but I think comments that Patrick and others have made, Susan Aronoff and others. But I did want to follow up on one of the things that were mentioned in the Disability Rights report that I don't think anyone's mentioned yet, and that is the supports for people who have dementia or Alzheimer's, and the lack of capacity and preparedness for hospitals and community systems to be providing kind of equal opportunity for community-based supports. I think that is a really critical issue, and it ties into both the issues that have been raised about the amount of control hospitals have, but also the lack of preparedness they have to work with that population of Vermonters, but also the tremendous lack of housing options with support services for people who have Alzheimer's and dementia. We have a lot we could build on that Vermont has learned to do with other populations of people with disabilities, but we haven't built the capacity or the resources to do that work. Thank you.
Thank you, Deborah. It looks like Patrick is raising his hand.
Oh,
I just said unmute. Tom, first of all, it's great to hear Deborah Lisi Baker's voice again. I haven't talked to her in a long time. But two comments I'd like to make about what we might do. The first one is very practical, and it's a constant barrier in any discussions about what we should do next, and that's about the money. And yet I believe that it wouldn't even be very hard to do an analysis in different parts of state government systems of what it costs to keep persons in an institution versus what it costs to keep persons in a more independent setting. I'll just give you one quick example. In the mental health system, according to the Disability Rights Vermont report, it costs $2,500 a day for somebody who's stuck at the state facility. $2,500 a day times 365 days a year is over $900,000. That is a lot of money. And I guarantee you, from my experience in state government, that you can serve in the community anywhere from 2 or 3 of the most challenging persons to God knows how many less challenging persons. But that you don't find that analysis anywhere on paper, anywhere. But nobody reports it. I would say the same thing is true about long-term care facilities. It's been a long time since somebody did put on paper how much it costs to have somebody at home versus how much it costs to have somebody in a nursing home. That's a concrete thing that we all should have in hand to argue with the policymakers who always throw up the lack of money. I would also say, even with developmental disabilities, if anybody, we have forgotten what it costs to keep somebody in an institution for people with developmental disabilities. And if you compare the cost of what we spend today to keep people in the community versus what it would cost if they were in an ICFMR, it's phenomenal. So that's one thing. Somebody should figure out how to do that analysis because, as I said earlier, I believe there's plenty of money in the system. The other thing I think I would like to suggest is more philosophical and less practical, and that's to approach each and every policymaker in this arena, from the governor to the Secretary of Human Services to the commissioners to the key legislators, and have them sign a pledge to support the Olmstead Act in Vermont, because I think that has been lost. When I think back to when I was in state government and some of the leaders we had then and what they believed about community integration and independence compared to what I read and hear today, we have lost a lot of ground. And I think we should challenge our leaders to pledge that their support to that idea and to that law again, publicly.
Great, thank you, Patrick. Sharon, were you waiting to speak?
Yes, I don't know how to raise my hand, so.
That's okay.
I would like to, first of all, thank Patrick for what he just said, because the Education and Independent Living Committee of the Silk has taken on the objective of looking at data, but it's extremely difficult to figure out where to find that data. The other thing I would like to suggest is that a pledge for Olmstead is a wonderful educational tool that we might be able to implement. The 11 categories that are in the Olmstead piece of paper now, I'm wondering if we could start by putting together some objectives, concrete objectives around those 11 goals, whatever. It just, to me, I've been around this for a long time. And what I find interesting in the aging process is what happens to folks with disabilities who are aging who I can't tell you how many times it's been recommended to me that I look at a nursing home or I look at a assisted living facility. Luckily enough, I know I have other choices, but we have to educate our medical personnel that there are other choices out there. And I don't think that that's happening on a significant basis. That's it.
Thank you, Sharon. It looks like Erhard has his hand raised, and then there's someone else on the phone. And I do want to point out that we are currently at 11:54. I'm happy to keep this meeting going beyond that. I understand some of you probably have places to go, and that's okay if you need to drop out. I did create some settings for this meeting yesterday that don't seem to have stuck. So if this does cut out right at noon, I am happy to restart it. And if people want to rejoin, hopefully that won't happen, but I'm just throwing it out there in case. So let's go to Erhard and then the person on the phone. And then I see Susan Yuan after that.
Hey, Tom, I wanted to pivot off of Patrick's comments around the respective costs of different levels of institutionalization and care. Is there? I found I think an answer to Patrick's question in a study that was actually legislatively mandated a couple of years ago, titled "The Roadmap to End Homelessness." Which was done by the Corporation for Supportive Housing, which is a national organization providing, they develop permanent supportive housing and work with many states. And we had them come in and analyze our systems. And at the end of their report, there's a great chart that I could, Tom, I don't know if there's, if I have the ability to share my screen, but I could show it on the screen briefly, and folks could kind of see what has already been done in terms of analysis of state expenditures on different forms of I guess, for want of a better term, different forms of housing. Is that possible?
Yes, sorry for my lack of response. I just made you a co-host, and that might give you the functionality to do that.
Let me try that. There it is. So I'm hoping everyone can see that. This is the estimated daily operating costs in Vermont. And again, this was done a few years ago, but you can see at the bottom end is $40 for permanent supportive housing. Of course, that doesn't include capital costs. That's ongoing costs for operating costs and supportive services. And then we have a motel voucher program that was $73 at that point a day. Assisted living, $132, and if hoping folks can see this, we get up to emergency rooms, and again, this was done in I think 2015, 2016, so it's almost 5 years old. $1,602, and I think it just really puts a very clear point on Patrick's point that there is enough money in the system. If we can avoid the kind of both inpatient psychiatric hospitalization, as well as reliance on emergency rooms, there is enough money in the system to provide permanent supportive housing for everyone that needs it. I was skimming through the great report that Ed presented earlier, and again, sorry I missed it, but I was also, it reminded me of a report that Wilda White did when she was executive director of Vermont Psychiatric Survivors, and she did in-depth interviews with, I think it was about 25 folks who had presented with a mental health crisis at emergency rooms, I believe probably mostly in Rutland, and 75% of them had come from homelessness, and homelessness was part of the reason why they were having a crisis. And they wound up being admitted to the emergency room, and they stayed there on average 21 days, as opposed to the 4 folks who had not come from homelessness. Or the 25%, I should say, of folks that had not come from homelessness, they stayed on average only 4 days. And I think that to me was just one of the most telling markers of how important it is to avoid crises that result from someone's lack of housing, and the extreme cost to the state of Vermont, and how much money is in the system that could be redeployed to help people live more successfully and more independently in the community with the supports that they need. I'll also say, and I won't share this as well, maybe when hopefully at a future webinar, Hillary or someone from Pathways Vermont does an in-depth look into Housing First. Pathways has done extensive analyses of comparative costs of folks that they have served. They, under a SAMHSA grant, the number of, that provided their startup funding for 5 years, they looked at a cohort of, I think, around 120 or 130 folks that they had served, and looked at their costs prior to being served by Pathways with Housing First, and then for the 6 months after. And the cost savings are just absolutely striking. And of course, the outcomes are just far superior, because people were living more independently with the supports that they needed in the community, as opposed to living incarcerated or living in some higher form of institutionalized care. So thanks. Actually not sure how I can read. There it is.
Thank you, Erhard. We were wondering about screen sharing for this presentation, and it seemed like that worked well. If that didn't work for people, that's something I'm very interested in for future webinars, to make things more interactive. But if that is a barrier for folks, please let me know. It went smoother than I expected it to, so thank you. Just before we get on to the phone caller, I did want to read something I saw come up from Monica. She just put out there that the Dale, Monica Hutt, excuse me, Dale Commissioner, the Dale budget testimony each year does address some of the cost issues. It's not perfect, but there are differences. It articulates the differences in levels of care, particularly the differences between community-based care and institutional care. And that's great. Thank you, Monica. And if there is is there ways to access that testimony? Is there a record of that anywhere that we could put up for folks? Not to put you on the spot right now, but just as a follow-up thing. And yeah, someone on the phone, and it looks like you're already unmuted. So if you just want to start talking, you can go for it. It's the 802-505 number.
Hi, thanks. This is Polly in Senator Leahy's office. I didn't realize that by unmuting it kind of virtually raised my hand. I just want to thank you so much for having this webinar and really bring this discussion to a forefront. I think right now is a really important time to be thinking of how we care for people outside of institutional settings, and it's an important conversation to be having right now. So thank you for pulling together the report and gathering us all, and I'm really looking forward to future discussions and thinking about how federal policy can help support your goals in Vermont.
Great, yeah, thank you for taking the time to be here.
Sure thing.
I'm not seeing any other hands raised. And again, please let me know if I'm missing anything. And thank you, Monica. Monica has put up a link for the budget testimony, and thank you for that. So I'll just give it a few more seconds here to give people an opportunity to chime in, and then we'll move on to the next talking point. Okay, I see someone else on the phone. Go ahead.
Hi, this is Deborah again. Just a sort of a placeholder for maybe one of your future forums is assistive technology and its importance in promoting the goals of the Olmstead and the critical challenges that we've been dealing with for 40 years and trying to eliminate some of the barriers to access to both to equipment, communication equipment, mobility equipment, other equipment, but also the timely and effective repairs. I keep hearing from people with different disabilities about these issues, more just as a placeholder for the future.
Absolutely. That's a great point, Deborah. And that is something that during the public health crisis, I've heard a little bit about just tangentially, even just the access to that equipment, much less the repair of it, the maintenance of it. How do you safely deliver and implement, install, or maintain assistive technology while proximity is a hazard? So I do think that is a great talking point. It looks like Susan Yuan wants to say something.
Can you hear me? Okay, very quickly, a couple of points. I was on the original Olmstead Commission, and my task was to look at family support. And I looked across studies that had been done over, there were 5 studies that had been done over a period of 20 years, and they all basically had the same message. And that was how we crafted the challenges around family support, that these things had been raised over and over again, and money had been spent studying them over and over again, and there hadn't been significant changes. And I think that the one thing I'll say in terms of a positive that I wanted to say before I got off the phone, and I wanted to say it before Monica got off the phone, but that is in response to the immediate crisis of the virus, there was some real action taken that made a big difference for families. And that needs to be acknowledged. And whether that's continued into the future once the crisis is over, I don't know, but that was a very positive step forward. And the other thing that I wanted to say is that when we had the peer navigators, we had an external evaluator who did a cost avoidance study of the amount of money that was saved the Agency of Human Services or the Department of Children and Families through the keeping the children with their families successfully. And the amount that was saved far, far more than paid for the actual cost that was spent on the program, but it still wasn't continued. That's it for now.
Got it. Thank you. And it looks like Sam has something. Sam, whenever you want to go in.
Oh, if I unmuted. All right. I just I've heard this from several people, and I just wanted to emphasize that perhaps going forward, because I know we're going to talk about themes and ideas, future webinars and action items. So I think we should emphasize, I mean, it's obvious to us, people on the call, I think, but emphasize, for example, before the policymakers, before the legislators in particular, the cost effectiveness. I think they do sometimes forget that. I know that when former Speaker Shap Smith spoke before the Silk several years ago, he had mentioned that the Silk, and I guess other groups too, reminded him that we have to think about the long term, that it's not just about, governing, so to speak, to use vernacular, by the seat of your pants. You have to think about what saves money while providing best services in the long term. So I think if we can make the case about the cost effectiveness, I really think that emphasis should be a thread throughout future webinars and the in-person meeting for that matter. Okay, thanks.
Thank you, Sam. And yeah, I think that is a common through line, and you're right, it bears repeating. And, I've heard other folks in the meeting, even here, talk about that, is that a lot of these measures is obviously, dignity and personal well-being is our priority, but it is also long-term and sometimes even short-term more cost-effective and more practical. And so that's definitely a big part of the education that we try to do, and very relevant to this conversation. I think, a lot of the themes that we are talking about or have, during this presentation have come up already. And, we can certainly keep talking about building off of those. But I feel like we are ready at this point to really start developing some action items, and I'm seeing some of those already as well. So I just want to get to that part of the program before we go too far over time. We're 10 minutes over already, and I know folks have a lot to do. And thank you for everyone who's still here, and thank you for everyone who had to leave early for coming. But yeah, let's talk about, I have some right here. I've been taking notes as best I can during this. But let's dial in some specific action items for future webinars, if people have ideas that really percolated with them so far. I'd be eager to hear them.
Tom, I was wondering, I see things popping up on the screen, sending us to different web pages, and they don't stay up for very long, so I didn't get a chance to get them. How do we get those? This is a technical question. How do we get those websites and things like Earhart put on the screen? How do we get those?
Yeah, so I can save the chat as a file and send it to you, so you can have all of that in an email. And if that, I have never done that before, so if that is still difficult to use, I can go through it and get you all the links in particular.
Okay, because I can't figure out how to chat.
Sure, and a lot of them are PDFs too, so I could, and I'm interested in some of it's stuff we might want to highlight on our website, things like that. So I can download it as a PDF and get it to you that way if that's easier too. But we can work that out offline, just to make it works for you. Absolutely.
Tom, you're talking about future webinars, and I certainly would agree that something geared towards housing options would be in order. Sort of following up on the idea of the cost comparison, there is, I think, certainly accumulating good information about what this kind of service costs compared to that kind of service would be a great sort of jumping off point for a webinar and compare it across different parts of the system, everything from choices to care, developmental services, TBI services, to all the different compartments that people have mentioned before, mental health services. But I think also we need to take a close look at the dynamic of, for example, the comparison between a day cost at the Vermont State Hospital, which I forget what he said was something like $4,000 or $2,500. Let's call it $2,500. A day's service through the community rehabilitation and treatment and mental health service is about $64 a day. So you got an incredible comparison there. But the real challenge is, how do you limit the fact that in an institution you are maintaining this whole infrastructure? So it's not like you can say, okay, let's keep 3 people out of there and we'll save 3 people's worth of dollars. It just doesn't work that way. And I think there are challenges like that that would be great if we could identify those kinds of challenges and show that when we develop a new psychiatric unit, like they're talking about, 20, 25 new beds in central Vermont, that will be an infrastructure that has to be maintained at a cost for all of those beds. You can't just say to the staff, okay, there's 3 people less here, so you 4 people can go home today. It's just not the way it works. And that's what we found when we closed Brandon in the 90s. The longer it stayed open and the fewer people there were there, the greater the expense per person was, because you had to maintain the institution. So we've got to look at the context in which these comparisons are made. And I think that would be a valuable way for people to be able to analyze policy decisions going forward before we fund a new 12-bed facility somewhere, a new 40-bed here, those kinds of things. So that's the long-winded way to say of comparing the costs and the practical mechanisms for closing institutional beds. We had the same kind of challenge closing nursing home beds.
Right. I think that is important to highlight. I think you're articulating the point very effectively, that it's not, people aren't necessarily looking at the inherent cost. They're looking at maybe like a line item and not like a long-term maintenance cost or something like that.
As an example, it costs approximately $6 million to keep Woodside open. And it's geared to serve, if you want to call it that, something like 30 kids.
Right.
There's 4 there right now, I think. And you're not saving any money because you still have to pay your staff. So, the cost is not relative to the exact number of people. So we have to think system-wide when we are looking at saving institutional dollars, which is what we did across the nursing home system when we shifted the balance and ultimately put in choices for care. And I apologize, folks, I have to get off the call, I'm afraid.
All right. Well, thank you, Ed, for everything you've contributed, and we'll continue the conversation. It's really valuable.
Thank you all very much. Really appreciate it, folks.
It looks like we have Sam. I'm seeing Sam, Missy. Missy, do you have something to say? And then Patricia.
If I unmuted. All right. I just,
No, this is Missy. I don't have a comment. I'm just getting ready to get off the call.
Oh.
Sorry there.
Oh.
Sorry there.
All right. Okay, didn't mean to step over you. Let me make sure I'm unmuted. Yes, I just wanted to say, it looks like a lot of people have to drop off at this time for obvious reasons. And so what I would suggest at this point is perhaps Tom may be collecting the themes that have been mentioned and could be culled from what we already spoke about, and perhaps sending it to the entire group for their consideration for future webinars. The reason I say that is maybe that makes more sense rather than leaving a lot of people out at this point of the discussion. People had to leave. Does that make sense? And then the SILP could perhaps put forth themes for future webinars, and maybe one particular theme for the next webinar. Okay, does that make sense?
It certainly does to me, and I do have a lot of potential action items, and I appreciate everyone who's put forward ideas so far. I think, yeah, it could easily be a list that I generate, and we can sort of feel out how people want to move forward with. Let's go to Patricia.
Hi, can you hear me? Okay. It was just a very quick comment, Patricia Tedesco from VCIL. When Ed was describing the reduction in residents like at Woodridge or Brandon, but this cost being the same, the visual I got was the educational system in the state and the country. And so I think people are fluent in that, in shrinking school populations. So I just wanted to throw that comment in there, that that might be a good analogy, because people already get that model, and that that it's not a cost savings, it's a cost burden the fewer students you have. Thank you.
Tom? Just one last thing that I wanted to say. It's not so much a suggestion for a webinar, but just a suggestion, as I know at the beginning when we talked about the Black Lives Matters movement and just the lack of diversity here. I don't know if that could be a webinar, but I think we need to have a discussion about why that is the case. Why aren't we hearing for the unrepresented in the community, and what could be done to do that? How can we reach out and get that? And I don't know if that's a webinar. I don't know if we can ask people who are part of those community to speak as to why they're not here, why they're not being heard. But I do think that would be an excellent topic to broach sometime in the future.
Yes, thank you, Nate. And to be totally honest, I was almost late getting on my own webinar today, having this conversation. And I think it's really important. I really appreciate that you're bringing that up. There's fatigue. I'm involved with other social justice groups personally and through this work here, and what I'm hearing from a lot of folks, and I don't want to make it, I don't want to make general statements, but anecdotally, what I'm hearing, particularly over the last 48 hours, is people who are working in social justice, particularly around issues affecting people of color, is that they are tired of reaching out to white folks, to be blunt about it. And I totally resonate with that personally. I totally understand that. I don't know, I think it bears conversation about the proper, what solutions are and how you go about bringing people into that conversation. Because I totally agree. And I think particularly this topic, Lois Curtis, is representative of the issues that we're talking about here, and representative of the issues that are happening nationally currently. And I think that is something that we absolutely should be conscious of in this conversation. And what I can do personally is make space to continue that conversation. I don't know how, I don't know how to really effectively communicate in that space right now. And that's something that personally I'm working on doing. And I'm definitely happy to continue to have that conversation. I know that's not It's not a satisfying answer, but it's an answer. You're muted.
Well, there, I just have to try to repeat everything I just said, and I forgot. I definitely see the point. It is difficult. I'm just trying to think of ways where, and it's kind of where you talk about they're tired of turning to white people for, and I'm just wondering if we do something where they're leading a webinar telling us their perspective. And I don't even know if it's a way to do it. But, and again, the other thing that I keep on wondering is the technology factor for a lot of people who are unrepresented or underfunding. You know, one thing I really liked about this is the number of people that we had here. I don't know if we could get this number of people in a live, you know, workshop. So in some ways, it's kind of cool to see how Zoom is allowing more people to get in touch with each other, and share their ideas. But on the other hand, I think it further provides a gap between the have and the have-nots for people who don't have that access to technology. But I'm just wondering, some things is I would like to have a webinar where somebody who is part of those underrepresented groups were leading us, just them talking to us and telling their perspective. And again, it's very tough to do, and there's so much going on. But it was just something that I'm trying to think about how I'm approaching things. And part of my viewpoint is like, okay, I need to start talking and start listening more. And I think that was just one of those things that I came up with. But yeah, it's a tough thing.
Yeah, thank you. And I think that that's a great idea. And, we certainly have folks in the intersectional work that we do that could be reached out to try to make some communication there happen. And I think, yeah, it's very important to be highlighting right now. So I really appreciate that. And it is great. It's great to see you, Nate. And it's great that so many people did show up. And it's, honestly, it's going smoother than I expected. And some, Murphy's Law will always affect us. And so some things right off the bat aren't going the way that I was planning, but it's going well. And I think that, the trade-off is that we are not accessible to people who don't have access to the appropriate technology. And, that should be part of a conversation that we are consistently having as well. I'm seeing Sarah and Sharon. We'll go in that order. And I also want to point out that we're pushing 12:30 at this point.
Okay. So just, yeah, I just wanted to say on the VCIL and VCDR Facebook pages right now, there are 2 upcoming events that folks might want to join. One around Black Lives Matter and the other from Justice for All. And it's a webinar. Sorry, my kids are playing music. One tonight and one I think on Thursday evening, so you can check that out. And also we're going to be rolling out some, VCIL received stimulus money to help address COVID-19 issues and from the CARES Act. And so we're going to be rolling out some programming over the next week or so, and technology access in addition to food access and that sort of thing will be part of that, where we're going to be offering up grants for computers and internet access and things like that for folks that we can. So stay tuned for that. Just wanted to say it since you had just said that.
Great, thank you. We can move to Sharon.
I just wanted to say this is wonderful. I moved from the Northeast Kingdom so I could be closer to the work that I love. And I've been asking the Silk to use technology. I think this is the way of the future so that we can include more people. Thank you.
Awesome, and thank you, Sharon. It looks like Sam's got his hand raised.
I just wanted to say, I agree with you, Tom. I think this went smoother than I think maybe any of us had imagined. And I think I agree with the comments that were made, just as chair of the Silk, that I think it was an excellent meeting. And as I said, it doesn't end here. It'll continue. We'll take from this whatever we need to and move forward, and hopefully we'll make a difference. That's all.
Awesome, thank you. And thank you, Nate, for your comments too. I'm seeing you have to leave. And I want to just go back because Courtney made a comment while we're having this discussion, just putting out WebEx as a potential platform to use if that's, you know, increasing access for some folks. And I just wanted to respond that personally, I'm happy to use whatever's, you know, I want to be flexible and the most accessible possible. You know, so we can certainly have, the Silk can have that conversation about what the best web platform is to be using. And thank you for that suggestion, because it sounds like, you know, we have the accessibility issues that we're trying to be conscious of, but then as we're seeing here in this meeting, we are also, there are, you know, if we want folks from the state attending, you know, they have protocols and procedures that are constantly in shift right now too, and I'm sure we're all pretty aware of some of the vulnerabilities that Zoom has had recently, and they're working on fixing their end of the software, but there's lots of considerations in terms of accessibility, and so I wanted to highlight that too, and thank you for your input on that. Do we have any other questions or comments? Ideas, thoughts? Got it. Well, I think, you know, the way to wrap this up is exactly what I think Sam suggested a few minutes ago. There's lots of ideas here, and I will sort of digest them into a bulleted list, like some of you know I like to do, and put forward some ideas for next steps. And, you know, I would encourage folks, just like what was happening here during this meeting, if I'm missing things or if I'm interpreting them wrong, you know, don't be shy to correct me or to be adding things in or to be changing the conversation, you know, how it's meant to be interpreted. And I want to thank you so much for the folks that were putting effort in, all the folks from DRVT, AJ, Ed, and Mary. Mary was a really big help in helping manage the chat during this meeting, which I really appreciate. And our ASL interpreters really, I feel like, went above and beyond for this and have been really helpful. Were really helpful in the planning yesterday. Set up a separate account to help people's access, and I'm just really impressed, and I really appreciate the work that you do. So thank you for that. I think that's what I got. We're at 12:32, and this was great, and I'm excited to do more. So I'm happy to leave it at that, unless anyone has anything else to say.
Thank you so much. Really appreciate it.
Thank you.
Yes, thanks.
All right, well, I hope to see you all soon. And it looks like the sun might be thinking about coming out, so maybe we'll go back to spring here. I hope you all get to enjoy it.
Bye.
Talk to you soon.